the living room to the Senate floor, from first responders to technology innovators. Different roles, different stories, but one goal: to meet the need for crisis care and overcome the obstacles together. So join in. The Crisis Jam is starting now.
Hello, and welcome to episode 232 of the 90-Day Crisis Jam. Today we're going to be getting started and looking forward to our feature discussion, as we talked about in the pre-show, with Ted Lutterman from NRI, discussing building their crisis response. So just a couple of housekeeping items. Remember, with our 90-Day Crisis Jam, just to use your speaker view, and remember to stay on mute unless speaking. Feel free to join in and put in lots of comments in the chat. This is still our current website for the Crisis Jam, is talk.crisisnow.com, where you can get registered for the Crisis Jam. Remember, you register individually. It's also where you can get access to all the past videos and episodes, content, articles from Stephanie, and being able to see those things. I'm teasing that we have a new website coming with a web domain name that's actually going to be easier to remember, but that's all the details I'm allowed to give at this point. And then obviously, like I said, you can see get all of our content and previous videos from before on YouTube and be able to check them out. So feel free to subscribe and like. Coming up, and save the date, 98 day, September 8th. We'll be here before we know it. We're going to do, the theme this year is compassionate help, anytime, anywhere. And there's some great stuff on the SAMHSA website for SAMHSA Toolkit in terms of backgrounds, social media, and other tools that you can access and use. Here's some examples of some of the focus things that you can see. And then I definitely want you to save the date for next week, episode 233. My dear friend Tanja Miles is going to be the moderator with our Principal Deputy Assistant Secretary, Dr. Art Kleinschmidt. And they're going to be talking about the miracle of recovery. And both of these folks have such a strong belief in the power of recovery, the use of peer support, the need to continue to bring a holistic, whole person value form of care to the work that we do. I'm really excited about Tanja and Dr. Art Kleinschmidt participating in this fireside chat next week. And then coming in September, and I think it's 3 weeks or so, we start season 6 of the Crisis Jam. The sneak peek of that will be September 17th. We're going to have Battle of the Bills. And we're going to have examples of multiple different types of legislation and some amazing legislation. I've heard Rep. Steve Ilsen and Senator Tina Orwell talk about some of the things that they've introduced in the state of Washington as well as the state of Utah. So encourage everyone to get your states and your state legislators to tune into this one and be able to check it out, because there's just going to be a wealth of information to understand some of the things that you can do in your states to further push forward crisis work and the crisis effectiveness. Now this, Richard, I'm hoping you can join and let me know when you're on. We are going to go into our hot seat in just a second. This picture, through the power of I don't know what, but it looks like there could be a little bit of a blur of a Photoshop in there. We have this picture of Richard McKeon in his office posting the paper. This really did happen. This picture, I'm not so sure, Richard, but you're looking sharp in it. Are you able to join? Let's see if Richard's on. If not, we will go ahead and move forward with the start of our, not on yet, but as you see, what the question for our trivia, we've got a twofold trivia question today. We're going to start with this question where the audience can answer, and then we're going to go with the over-under on that. So that did happen, and Dr. McKeon did take the window of his office at SAMHSA so that others walking the hall would see it. Would it be A, a statewide crisis line dashboard, B, a flyer to sign up for the SAMHSA softball team? And by the way, Richard was an excellent player on that team, from what I've heard. This was about circa 2008, as David said in the chat. So just to give you a time sense of that. C, the suicide risk assessment logic map, or D, a timeline for a national 3-digit hotline. So let's enter in our answers. And let's get the showdown. Okay, so we've got number one is the timeline. We've got one for softball. Plug for Richard getting people to sign up. That may have been something on the wall at some point too. And then 15% for statewide crisis line. So let's go to the answer. And the answer is dashboards. So the primary goal, the primary goal of these dashboards we can put up was to get moving forward on creating and hanging. And he hung up this one from the state of Georgia to be able to get this moving forward and thinking about that. So I don't think Richard has joined yet, but let's. Oh no, he is. Richard's here. Hey, Richard, can you join?
I'm here.
Great. First of all, what do you think of that picture of you hanging the? Did you get to see
I
that?
was
Look how
I
sharp.
was impressed. I had no idea anyone had taken that that picture. I was, and I like it because I look younger then.
And Jane is asking in the chat, Richard, what position you held on the SAMHSA softball team?
Pitcher.
Pitcher. Okay, I thought that was. I had heard that, but I didn't know for sure. So that's good. So we've got a pitcher. Richard,
And
we're
I
going to go.
wish that I had been planning the 3-digit number since 2008. I cannot claim such credit.
Yes. And as Jane said, still pitching for better mental health. That's great, Jane. So we're now going to go to the second page. So Richard, starting back then and putting that first dashboard up. So where would you guess now, and I want you to set the number of where you think how many states have a statewide dashboard, and then the audience, once you set the number, is going to pick between over under.
Yeah, so I've been aware of several. Obviously, Georgia was an innovator, but I know that's certainly grown since then. And I now know the number exactly. But when I was initially asked this question about an hour ago, my estimate was 9 states would have something like this in terms of a statewide dashboard.
9 states. So that's the set. So if it is 9 on the dot, Richard, you win. We're going to ask the audience to think through, is it over or under? Now, do we have an actual poll to click on that over or under, or are we just going to be putting in thumbs up or thumbs down in the answers? Thumbs in the chat. All right. So let's get just a second or two to throw up what you think. I see a lot of thumbs ups so far. All right, it's universal that we've got thumbs up. So what are we, Ted, do you have the answer? Ted, can you jump on real quickly and give the answer?
Well, you're stealing one of my slides. I'll present in a little bit, but we have 21 states reporting they have a public dashboard of crisis data, and there are a number of additional states have internal dashboards tracking what's happening on crisis services. So there's a list of these, and this is available if people want to click on the links to see what the different states have up.
Well, thanks, Richard, for coming on and walking us through that. It's amazing that we've gone from that one back in 2008 to moving forward with that number. So with no further, let's see. So today's episode is going to be working on talking about episode 232, building the crisis response. But before we get to, here we go. Here's your slides. Sorry about that. And Ted, I do want to introduce this. Is a paper by Nashville's Research Institute that Ted first discussed and shared in the annual conference. It really did, I thought, a great job of kind of summarizing the momentum and where we've gone from 988 and how it's impacting states around the country as they're evolving that, and shared some really not just what's being done, but also starting to branch into some of the outcomes of those things, but then moving us forward, a lot of hope for things that we can continue to grow in the future. So with no further ado, really looking forward to hearing from you, Ted.
Terrific. Well, thank you. So, and I want to start by thanking you, the Crisis Jam, for letting us share some of the work we've been doing with states to document their work implementing the full continuum of crisis services, starting to measure some of the outcomes across the continuum. And I want to thank the dedicated staff in the states who answered our questions, reviewed draft reports, provided edits. We ended up with responses from every state plus DC, and we even have some information from Puerto Rico and a couple PJs. And I also want to thank the CMHS and SAMHSA 988 crisis team, who, although SAMHSA did not fund this, this is entirely a state-funded effort. They did provide some great review of the questions and suggestions for what to collect. Also, we did share at the NASHPD annual meeting in July a set of what we thought were final reports. And we did then after that get a couple states go, oh, I didn't realize we didn't give you this data. And so last week we've been plugging in. And so the slides I'm presenting today actually have a few more mobile crisis teams, crisis stabilization programs, and by Friday we'll be putting up on our public website some updated reports. But if you have to leave early, this slide sort of highlights some of the key points. In 2024, the state behavioral health crisis system supported states delivering over 9.94 million different contacts. Over $3 billion were being spent to provide these services. And this was looking across the three sort of major SAMHSA parts, you know, someone to talk to, someone to respond, a safe place for help. You know, there were over 503 dedicated behavioral health crisis call centers or contact centers, 202 lifeline centers in the states, over 371 local local crisis call centers, either run by the state, by CMH, community mental health centers, CCBHCs. We now have over 2,448 mobile crisis teams. That was 283 teams that do adults or all age groups. And a number of states are setting up child specialized teams, usually following the MRSS model that came out of Connecticut. And we see states reported plans to open at least 168 more mobile crisis teams this year. And then crisis stabilization programs. We had over 807 stabilization programs. I say over because California, for example, has a county-run system, and they said they didn't have a full count of all of them. But there are also plans to open at least 110 more crisis stabilization programs this next year. If you go to the next slide. And this sort of table just sort of shows how many teams, how many responses each of these settings handled each year, how much money was going to those programs, any plans for new programs, and also the issue about, are these services available statewide? Are they open 24/7? And I'll get into this in a bit more detail, but we wanted to give people sort of one overall snapshot that shows across the system where the 9.9 million people or contacts were and the $3 billion in expenditures. And you could see the plans for, you know, states planning to open up more crisis lifelines, more mobile crisis teams, crisis stabilization, and then the short-term crisis residential programs. And within the 807 crisis stabilization programs, we are trying to get some more details. So we did use the new SAMHSA definitions that try and break out what is a crisis receiving program. So there were at least 40 states have the sort of emergency room empath-based system, 119 high-intensity emergency centers, 228 crisis high-intensity extended stabilization programs. And then a number of states still have the medium intensity programs that are either less than 24 hours only, or that include 24 hours and extended stays, but only accept voluntary patients. And there will be a report that breaks out all these details on crisis stabilization programs, how many have dedicated law enforcement drop-off, medications on staff, et cetera. So if you go to our website, there'll be a lot more information there. The next slide. So the other key is we have this 2024 data, but we've been doing this for 3 years now, and it's showing this tremendous growth across the system. And so we see that the number of calls to 988 or contacts, calls, text, chats has gone up, this huge increase from over 1.6 million. This was actually before 988 was fully implemented to today over 5.3 million. The other crisis contact centers jumped up, and then it's sort of been stable. And we think part of that's because a number of states have been transitioning some of their existing lifeline or their existing contact centers to become part of the 988 system, or they've stopped advertising a state number and instead focusing on using the 988. We see the number of mobile crisis people responses have gone from 288,000 to over 1 million. And similarly, a big increase in the number of people getting crisis stabilization services. But I do want to caution, part of this is we've had more states reporting data this year than we did in 2022. In part, states didn't have their data system collecting all the information 2 years ago. So I'll come back to that in a couple other slides in a little bit. So the next slide, please. So this data comes from our state profile system, which was something that the states had us set up working with NASHPT to collect comparable data from states to use for their policy and operations. This is funded and controlled by states. So each of the states contributes a little bit of money to help pay for this. There's a steering committee that's led by Commissioner Marie Williams from Tennessee and Dina Stoner from Texas, and then other commissioners. And each year it meets and looks at what are the key topics that states want to know what other states are doing. And then we put together work groups of experts to develop questions to figure out exactly what data exists elsewhere and what would be new questions. And then we work with the states to gather that information. The states are sent drafts of everything before the reports come out. The last year we focused on crisis services. There was also a focus on forensic services and what states are doing to keep people out of jails and out of state hospitals in the community. Section looking at state organization and restructuring of mental health services, and questions on how states are using their state hospitals and how they organize their community system. So there's other information available on those topics for states, but today we're talking about the crisis data. You go to the next slide. So for the crisis component, we really focused on the 3 core components from SAMHSA's guidelines: someone to contact, someone to respond, a safe place for help. For each of those, we've got information on, the numbers of programs, the number of people served, how much was spent, what were the funding sources, what organizations operate it, are they available 365 statewide? If not, what are state steps to address it? There are questions around some of the workforce initiatives for mobile crisis. There's information, for example, on what organizations do the dispatch and how they do dispatch. For crisis stabilization, a lot more information about how they structure, what exactly they mean when they say crisis stabilization, information on the models used by the state. And then we also have some additional information on short-term crisis, residential, peer respite, and other state crisis services. Next slide. So, and the next slide, please. So this just takes that first slide about the growth and looks at it sort of as percent change. And what we see is the number of programs for 988 has gone up a little bit, but most of those programs were already in existence. But there's been a big growth in the number of mobile crisis teams, up 84%, in crisis stabilization programs since 2022. The number of contacts, you see this huge growth. 988's, more than doubled, up 227%. Mobile crisis, up 263%. Crisis stabilization up, and similarly, the funding has gone up across the board. So 988, although there are only a few more programs, they're handling so many more contacts, and funding has doubled, up 103%. If you go to the next slide. Now, as I said, the part of it, we weren't sure how much of it's because we had more states reporting than in this year than earlier years. So we also, the red or orange bars are states that gave us a number both in 2022 and in 2024. And so then we see the number of contacts at the 988 crisis center is up 157%, up, more than 1.5 times more. The number of people at other contact centers actually slightly decreased. Still a 40% increase in the number of people getting mobile crisis services, and over a doubling of the number of people getting crisis stabilization programs. But there were only 21 states that had numbers for both years. We also, though, in talking with states, think this is a bit of an undercount because some states did not have a crisis stabilization program, or they did not even have a mobile crisis team in 2022. So they didn't give us a number that year because they didn't have the program, and now they do have it. So I think we're going to be going back to states to try and figure out a bit more how to calculate the growth. But no matter how we look at it, it's been this impressive growth across the system. If you go to the next slide, it's the same picture for funding sources. You could see the overall with all states reporting, and then the orange bar are for like the 34 states that gave us how much money they spent for 988 in 2022 and 2024. The mobile crisis, it's spending over doubled for just the 27 states that gave us a number both years. So the message was really the states are spending a lot more. There are more people getting the service, more programs, and more funds. If you go to the next slide, as this map shows, every state has a 988 system, but there were 36 states reported supporting these 371 other crisis contact centers that handled over 2.6 million crisis calls, texts, or chats last year. And in some states, the way that mobile crisis is being dispatched is a combination of 988 and these local lines, or 988 local lines and 911 or other systems. But it's just important when we're talking about crisis contact centers, 988 is becoming increasingly the major source, but there are still these major other systems that are handling crisis contacts. Next slide, please. This shows how many mobile crisis teams there are in each state. Of the 2,400 some, you see they range from one mobile crisis team in one state to California had over 400 mobile crisis teams, 462 across their state. So there's information on how many teams are in each state. We also have how many people were served in each state. The next slide is a similar picture for crisis stabilization programs. Again, you see from states that don't have any, but several of those are planning to open one this year, up to 123 crisis stabilization programs in one of the large states. You go to the next slide. One of the other things we're looking at is, as I said, are these services available to anyone, anywhere in the state? The call centers are available no matter where you live, but what we see is still an issue and a lot of room for improvement that for mobile crisis teams, 32 states said they're available statewide, but 17 states said they're only available in parts of the state, typically in urban, suburban areas, but they're still needing to get them into rural areas. And not all mobile crisis teams are open 24/7, 365 days a year. 27 states said they are all their teams are operating 24/7, but 4 states said that none of their teams are yet running 24/7. And similarly for crisis stabilization, 15 states said they're available throughout the state, but 30 states said they only have mobile crisis teams in parts of their state. So depending on where you live, you may not have access. The next slide shows how this is growing over time. So we do see not only are more states having these programs, but they are expanding the 24/7 access, for example, for mobile crisis. It's gone from 20 states to 21 states to now 27, saying that they're all running 24/7. And similarly, we see a decrease in the number that are only some of them are 24/7. And similarly for statewide, we see an increase up to 32 states where they're all available statewide, reduction in how many are only available in parts of the state. So there is progress, but there's still, and one of the things we collected is policies and initiatives to try and broaden the access to make them more statewide, or at least to get them 24/7. Workforce being one of the key issues that states are struggling with. In terms of funding, this sort of breaks out how the funds are spent across the nation, the $3 billion. You could see also the average expenditures per state. So there's really a lot of money that the states are putting into this. The next slide looks at what are the funding sources. State general revenues are being used across the board, but the mental health block grant and SAMHSA funds have been critical also. The 988 grants that SAMHSA has, but the mental health block grant has this 5% set aside. What's interesting is states are using it differently. So some states are using the 5% to support their crisis contact centers, other states for mobile crisis, others for crisis receiving centers. Medicaid is being used quite a bit for mobile crisis and crisis receiving facilities. But one of the issues that we really would like to focus on is private insurance, where only a few states say they're getting private insurance for even mobile crisis or crisis receiving. You know, they go out and serve anybody, even if they have private insurance, but states are struggling to get insurance to pay its share. Next slide, please. This was that map that we talked about earlier. So the states are collecting a lot of data on their crisis system, not just 988, but mobile crisis teams, crisis stabilization, being able to look at where people move through the systems. Some dashboards really just focus on 988, but some states have their dashboard covering the whole continuum of crisis services. These are all hot linked, so you can go and see which states have what. And there's a report on our website that has this where you could download and get the data. Next slide. In terms of outcomes, what we see is the crisis system really is working. In median state with 69% of crisis contact center calls were resolved there. They did not need anything else. 4.9% on average, or 3.4% of median, ended up with mobile crisis being dispatched. Only about 1% had law enforcement or EMS being used to respond. 13%, resulted in scheduling an outpatient or substance abuse visit, but not needing more intensive immediate services. Next slide. Similarly, for mobile crisis teams, 67% were resolved just when the mobile crisis team was there. They didn't need anything else. 17% ended up with them needing some additional care, going to a crisis stabilization program, or going to an emergency room was about 12% on the median, 15% on the average. The next slide. And for people that go to a crisis stabilization program, 81% on average, 88% was the median of people that were seen there. That was all they needed. They did not need to go on to an emergency room or to some other more intensive level of services. So the last slide I have here sort of puts that all together. We're trying to make this a little cleaner. If you go to the next slide, out of 100 calls to a crisis contact center, 81% of them were resolved by the person being, 80% were resolved by the person just done contacting the call center. 21 people ended up having mobile crisis dispatched. Less than 2% ended up with law enforcement or EMS. And of those that mobile crisis saw, the 21 people that mobile crisis went to, again, almost all of those people ended up being resolved just by mobile crisis. Only 4 people, 4.2, went on to need a crisis stabilization service. And about 1% or 2% had law enforcement or some other response. And then of those who went to the CSU, the 4.2 here, again, most of those had it resolved. Only 0.12%, less than one person, went on to an emergency department or a psychiatric hospital or other settings. You could see one person. So overall, out of 100 calls, by the time you get through the crisis continuum, 97 or 96 to 97 had their cases resolved successfully without needing to go to intensive care. They didn't need to go to an emergency room, to jail, or to a psychiatric hospital. So this is really what we've got. If you go to the last slide, I'm sorry if I went over on my time. The reports are available on our website at www.nriinc.org. We're going to have the updated reports with this last data that came in from states up by Friday. And we're working already with the steering committee to plan the next year's cycle. So if there's state people who would like to be involved, we'd love to get more people's ideas on what questions to collect. So we're going to be meeting in September to start planning the next cycle of data.
Ted, thank you so much. Unbelievable amount of information about things that are happening, the momentum of 98, but still a reflection of some of the fragmented care and the growth that we still need to have, as well as continuing to improve. And even in the chat, it was sharing things that other pieces of information people would like to see and understand more about impact on the system. But the ability of you to be able to show, and that really great slide at the end, the impact that the current system is having is really nice. And with that, I'd like to introduce our roundtable. Will be Dr. Matthew Goldman. It's so good to see you back, Matt. And you serve the perfect wear of two types of hats, both being able to look at data pieces like this and give your thoughts and dissect it and help explain it to all of us, some of the insights and things that you see, as well as being part of design a crisis system with your other hat and how that fits into some of the things you're talking about. So really looking forward to hearing you share what you're thinking.
Yeah, thanks, Chuck, and thank you, Ted. Amazing amount of information shared. There's so much to respond to and react to. I tried to consolidate my thoughts into 4 comments, which I will share here, and the last one has a slide that accompanies it. So the first is just to put the volume of services in perspective. So Ted described 5 million 988 calls, 3 million additional calls to call centers. I think I got that right. 1 million mobile crisis contacts. That is amazing in terms of the just volume of people who are served. And let's think of that relative to, there's a national sort of estimate that 911 calls annually across the United States number about 240 million 911 calls in a year. And there's sort of ballpark guesses that it might be about 10% of those calls are behavioral health related. So maybe call that 24 million 911 calls nationally happening every year, which then are likely to get some kind of dispatched resource, most often police. So 24 million versus 5 plus 3 plus 1, so that's 9 million service contacts plus the crisis state, which I'm not even counting in that figure. We're starting to get on track to reaching the scale of what 911 has done historically. And I think that's something that felt like, oh my God, 24 million calls a year. How are we ever going to get anything close to that scale? But we are on track for that as a system nationally. And that is worth recognizing in terms of major impacts on diverting calls from law enforcement response when appropriate, diverting 911 calls. So, with what Ted shared, there's clearly exponential growth happening year over year in terms of, utilization of these services and scaling of these services across the continuum. Given that we're starting to get close to the scale, it does raise the question of what is the total demand? Like, what would at scale look like? And again, we're on track for that. I think we're gonna, as a field, start having to really understand, like, well, are we at capacity? Have we saturated, supply to meet the full demand? And when that happens, we're then going to need to start moving from an expansion mindset more into what I think should be a quality and evaluation mindset. So it's like, okay, we've done the extremely hard work, the big, big lifts of moving these things to scale. And now how are we doing? And really moving, 911 and emergency medical response has such a quality sort of orientation to it, quality of care, standards of practice. I think those are things that, once we're done with the growth phase and really transitioning into the sort of stabilization of the field phase, that's going to be exciting to see how that all evolves. There's one part of the continuum that still has a lot of growing to do that I want to call out specifically, which is the crisis stabilization and residential part. That is the part where, as Ted described, there's the least access across the states. There's sort of the least quantity of those. And it makes good sense why. It's the hardest to scale because it's the most expensive to stand up. It's got capital costs, you've got a ton more staff. It's just a much more complicated program model. From the costs that Ted cited, of the 3 billion annual that were described as being invested in crisis services across the whole continuum, half of that amount went into the facilities, 1.5 billion. So even though it's the least developed component of the continuum, it's already by far the most expensive component, and so scaling it will continue to be challenging. And so, it's very uneven across the country. There are some areas like where I live, King County and the Seattle metro area, where we're lucky to have local investments. Our county passed a property tax levy to fund development of crisis facilities, 5 facilities over the next 9 years to the tune of $1.25 billion. So there are some places I'm lucky to live in a place where there's this huge local investment. I also live in a state, Washington State, where we have a state bill that requires commercial payers to reimburse for crisis stabilization services. And so parity laws have made that possible. But it's really in the crisis stabilization space, I think, where there's the most vulnerability to the lack of insurance payment, which Ted named, and I saw some comments in the chat as well, that, the lack of Medicare paying for crisis stabilization services and the lack of commercial payers following in suit in all states except for the handful that have a parity bill that requires them to. That is the major gap. And that's where, maybe a local investment could more easily stand up mobile crisis because it's less expensive, but it's much harder for local investments to stand up crisis stabilization. We really need insurance universally to be paying for those types of services in order to reach that full scale that I think many of us recognize is needed. My second to last comment is I love the SAMHSA continuum of someone to call, someone to respond, somewhere safe to go. I believe there is a fourth part of the continuum, which is someone to follow up. And that's something that I've rung that bell for a long time, and I'll ring it here again. And the reason for mentioning it here is, and this is related to quality, what is the impact on all of these expanding crisis services on downstream services, on referrals to outpatient care? There's look at that. Oh my gosh, I didn't even know that this is here. That was like totally a plant. So someone to follow up, thank you. And I think there's a couple ideas of how crisis services might impact outpatient services. Some have the idea, well, we're going to open up all these doors to access care, and so that's going to flood demand for outpatient services, and outpatient services are already saturated, so how is that going? But then there's also the idea that right now, kind of everybody gets shunted into outpatient services, but if you have a crisis service that's able to resolve somebody's crisis in that moment or just in the near term, you might not need to send all of those folks to outpatient care. So that might actually open up some capacity in outpatient downstream services. We don't know what that balance is in terms of much more access, needing more referrals versus people who are having service needs met in crisis settings and then not needing outpatient referrals and diverting from outpatient settings. And so that's a big unknown question and something that I think we look forward to hopefully being able to characterize more as part of this continuum, what really is the impact on outpatient care. And then the last comment to make here, which perfect timing for this slide, is the state level data that Ted shared and worked so hard to collect is essential. There's also a lot to be understood at the program level. So many of you might recall that there was a mobile crisis survey that we conducted nationally. Preston Looper and myself did this with the support of Vibrant and SAMHSA a few years ago. And I'll put the link to the first version of the report in the chat. But we are very excited that Pew Charitable Trusts has funded a second version of the survey. And so this is coming this fall. I'm giving a kind of early heads up that this is coming and really encourage you all to spread the word. We're going to be doing, again, the national survey, trying to get as many mobile teams as possible to respond. We're keeping a broad definition, so this would include mobile crisis programs, sort of traditional traditional ones with behavioral health providers, but also MRSS programs for youth, alternative and community response programs, co-responder programs that are primarily based on law enforcement with a behavioral health co-responder, really wanting to cast the net wide and both do a national survey, and we're also doing deep dives into 5 states to get complete data on those states to really understand capacity, adequacy, network adequacy, accessibility of mobile crisis in those settings. So very excited for that work to come, but thank you for
Matt,
tuning in to my long ramble and comments, but really excellent stuff, Ted.
it was
Thank you.
not a ramble at all, Matt. It was amazing summary and some really key 4 points to kind of summarize for us that just generated tons of follow-up and kudos and agreement in the chat. So thank you for your time and expertise in sharing that, Matt. Richard, we're going to bring you back and kind of get our SAMHSA update.
Thank you. Thank you so much. Very much appreciated it. So just a couple of things that I wanted to make sure to mention. Of course, all of you are aware that 988 Day is coming up, and we put out information over the last several weeks about how you can support 988 Day. The Suicide Prevention Branch at SAMHSA has also put out information regarding how you can participate in Suicide Prevention Month. Staying here in August, however, wanted to make sure people were aware that later this afternoon at 2 o'clock, Vibrant is putting on a webinar on the appropriate use of emergency service interventions in 988 Lifeline Conversations. This is a session that's going to offer updated guidance on building and maintaining effective relationships with local public safety answering points, as well as strategies to navigate common challenges that may arise in these collaborations. Of course, this is all in the interest of minimizing the need for emergency service interventions when they are necessary, maximizing the likelihood that they are voluntary rather than involuntary. One other thing, and this is not SAMHSA supported, but I think it's worth highlighting and thinking about. In this month's suicide and life-threatening behavior, there's a very striking original article called Rates and Reasons for Concealing Suicidal Ideation from Clinicians, a cross-national examination. And this, what they did was that they took a sample of over 6,000 people with a lifetime history of suicidal ideation and asked them, have you ever denied or concealed thinking about suicide from a doctor or clinician? So not specific to crisis services, but more broad. But one of the things that I found striking was that the rates of non-disclosure among participants who reported lifetime suicidal ideation range from 7.2% in Taiwan to 48.2% in the United States. So that's something that I think would be worthwhile for us all to kind of dig into further. Again, this is not 988 specific, it's not crisis services specific, but it does say something regarding the mental health system. The study also looks at various, inquired about rationales for either denying or concealing suicidal ideation. So it'd be a fascinating thing for us to perhaps talk about in a future crisis jam. So that's it for the SAMHSA update.
Thanks so much, Richard. That's a really interesting topic to think about. And again, it helps us reflect on what are we doing in our system to make it easy and safe for people to be able to share what they're going through and understand that and the impact of those things. Wendy, thanks so much for being with us. Wendy Bailey's been for our Nashville update.
Thank you for having me. I am going to just briefly talk about our crisis continuum of care in Mississippi. And Matthew, keep ringing that bell because you'll see on my slide, I've got someone to follow up as well. I'm right there with you. So in the state of Mississippi, we really do have most all of the components built out, but we're still working and we're still continuing to improve those. Our 988 calls just over the last year have increased by 15%, increased by about 16% the year before. So we know that more people are, of course, learning about 988 and taking advantage of using that first step in that crisis continuum. We average about a 97-98% in-state answer rate in the nation, so we're very proud of that. We only have 2 call centers in our state, but they are very, very well run and operated and well trained. So, and we have an amazing person, Jaquilla Newson, who's over our 988 efforts here at our state office. So we also have mobile crisis response teams. And as Ted mentioned earlier, Mississippi's teams, we have one in every region, which we have 12 regions in our state for community mental health centers. And they had right at about 8,000 calls last year, a little over 8,000 calls in this last fiscal year. And they do respond 24/7 for adults and children. And they also respond to people who have intellectual and developmental disabilities as well. We've had a very large push in our state that crisis intervention teams also fit within our someone to respond. And many times they will go out with our mobile crisis response teams. So we actually had legislation pass last year that all county and municipal law enforcement entities have to have at least one CIT trained officer. And we have hit that goal and we have them trained now. And then we're adding more CIT officers, and all officers have to be trained in mental health first aid. So that is really helping when our response, when law enforcement is involved, and helping the de-escalation of that. We also have Somewhere to Go, which in our state, we have 2 peer respite programs. We're so excited. One's still up and going and one opened up the end of last year. But peer respite was something that we really wanted to look at and expand in our state. We have 2 hybrid crisis diversion units. So you would have the living room model and then also crisis stabilization beds as well that we're working towards. And then we have crisis stabilization units, which really is more along the terms of crisis residential. It's just we still call it crisis stabilization. But those crisis residential units served almost 4,000 people last year. But what's incredible about those in our state is they have a 93% diversion rate. So if you go to a crisis stabilization unit, 93% of the time, you do not have to go on to a state hospital. So those are very well run in our state. However, we can go to the next slide. We know there's still gaps. So the road that we're on in Mississippi to address some of those gaps are the Rural Healthcare Transformation Program, which I'm sure all of you on this call are very familiar about. We're doing a proposal in our state for our governor for our psychiatric emergency services. We're calling it PES. That's the less than 24-hour care for a psychiatric emergency, where we could do some medical clearance and partner with some rural hospitals to be able to do that as well. And then we would be able to move someone onto a crisis stabilization unit if needed. So we're looking at several different models for that psychiatric emergency service to really build out that part of our where do you go. Again, the peer respite programs, we're excited and want to expand those as we move forward, and our 2 hybrids, the SUs that we're looking at opening in 2026. We also know, though, and I know you all do as well, your services are only as good as your workforce, and your workforce must be trained. And when you're responding also to crisis for mental health, substance use, and many times IDD and dual diagnosis, we used a TTI grant. I'm advocating for TTI here. We used a TTI grant to do a monthly crisis training that we are doing with stakeholders across our state. And then we're also building out that training series that can be placed on a learning platform to where all new employees are able to do that as well and have access to those trainings, because we know with staff turnover, you've got to train your new staff coming in as well. So we've been excited working on that project with HMA. And then the last thing that we're doing that's also, I feel like, part of the crisis continuum is many times when people go into the correctional system, when they re-enter into the community, they do not have access or knowledge of the mental health resources that are available to them and substance use resources that are available to them. So many times you see re-entry back into the correctional system or someone in a crisis situation. So we have started a re-entry program. This is TTI2. We started a re-entry program in the 2 women prisons in our state, where we're going to have peer bridgers established, working with NAMI, Mississippi, to also have groups and then work on bridging those people as they're re-entering back into the community with the resources they need. So we're very excited about what we've accomplished so far. We've got far to go as well, but we believe firmly in the crisis continuum and look forward to learning from other states as well as we keep building it out. That's all I've got.
Thank you, Wendy, for sharing a statewide story of those outcomes and momentum going on. All right, I'll bring up, hey, Ursula, are you ready to join?
Hi. Hey, Chuck.
Hey, we are looking forward to hearing you talk a little bit more about this important topic. Quick story. No lie, I had no idea you were coming on today to be able to talk about this. I was just sharing about your website and the work you do, and a lecture I was doing related to suicide care to some of our counselors at an opioid treatment program in a rural area in North Carolina, and how helpful of a resource that is, because there's no DBT groups or other types of support groups in that area. So it's just apropos to be able to see you and have you share today.
Yeah, thanks to David for having me on today. I have a couple of slides to share. Some of you have been aware of the media in the last couple of weeks about ChatGPT and suicide, and people using using ChatGPT or other live chatbots as therapists. And you find conversations in communities like Reddit where essentially people are building their own AI therapists, so teaching ChatGPT how to become to be the best therapist. And so they'll take this example from, per se, Reddit and put it into their own ChatGPT and give it guidance like, please don't give me recommendations to reach out to other people for help or do these things. And a couple of the stories that we saw, and I'll see if I can just share here my screen, were about younger people and their experiences. And so in the chat here, what I'm sharing is a link to a document that has links to some of these stories and the personal experiences. So one was Sophie, whose mother wrote an op-ed about her experience and conversations over months that ultimately culminated in AI helping her refine her suicide note. So what we're finding is that, and I'm going to talk a moment about our peer support groups that my organization Now Matters Now runs. We're finding that people are they're really using these for therapy, and by and large, you're finding them very helpful. And then there are these use cases where this type of validation that the AI is meant to do goes terribly off the rails. And another example is Adam, who was even sharing, images and stuff. And there was this subtle sort of reinforcement, unfortunately, of the behavior. And I think what we're here to do is to say that there are alternatives to these type of things. And so let me just share for a moment here. So these are the examples of the stories that I was mentioning. And that link there goes to the document I was showing with some of these. So I'm a CEO and founder of nowmattersnow.org. We've been around for a long time, but we recently put full effort in and received funding to build out our platform, which includes the largest, most comprehensive online resource for DBT skills. So those skills are focused around storytelling, people with lived experience, like myself, talking about how they got through those moments, suicidal crises without and made it to the other side, like very specific details of how to use these skills in stories. We also, over the past year and a half, been rolling out these peer support groups. Ultimately, that will be like the AA model, where there will be these ongoing DBT skills type support groups that anyone can join and be available 24 hours a day. And we also have a public health intervention that was recently shared in and Oprah Daily about what steps a person can take when they're on fire emotionally, when they have these overwhelming urges to die. And so we really want people to know that there are alternatives to this black box that people are in. And we have to figure out how to get that information out there, because we know that people are going to continue to use these resources. It's what's there in the middle of the night. It's without judgment. There's no repercussions. They're not going to get in trouble. And how do we meet and help with this situation to meet people where they're at? So if you're interested in learning more, you can drop a note in the document that I shared in the chat. You can also visit our website and learn more. We have these ongoing meetings running. We're slowly scaling up and building out, making things as good as possible, that someday these can be all volunteer run. They are already all volunteer run, but we have extra supports in place. So thanks for giving me a moment to share about that. And I'll turn it back to you.
Thank you, Ursula. Like I put in the chat, I've had several clinicians who found the training videos just extremely valuable, and it's so much information to share for people that need those resources. So really appreciate you going through with that this day. Want to thank Paul Gallis. We're going to move his Medicaid talk to just in the future. I'm going to bring in Heather Honaker real briefly to talk about our upcoming Crisis Con to see our crisis buddies in Indianapolis. I'm looking forward to that.
Hey, thanks, Chuck. Hi, all. I'm Heather Honaker, president of Crisis Residential Association. Please forgive me. I'm coming to you from the airport, so hopefully we can get this done pretty quietly. But I wanted to come on just to share with you about Crisis Con. We are partnering again with the International Council for Helplines to bring the National Crisis Continuum Conference to you. We will be in Indianapolis, Indiana from September 28th through October 1st. Registration is still open. We're expecting hundreds of your peers. Many of the people that you saw speak today will also be presenting. And so if you haven't heard of Crisis Con, check our website out, learn about our speakers, our keynotes, all that information is up there. And we would love to see you in Indianapolis. Thanks, Chuck.
Thanks, Heather. See you there. All right, so I'm going to bring on Stephanie. We've got just a few minutes, Stephanie. I'm sorry to put you in a tight spot on this, but I'm really excited about you sharing this with Ryan. I've seen Ryan present this at last year's Crisis Con, and it's about services that are in my hometown of Durham, North Carolina.
Thank you, Dr. Chuck. So I'll bring on Ryan Levi. He's a reporter and producer for Trade-Offs, covering Medicaid, mental health addiction, and health technology. Ryan, we have just a very short window of time, but the article is fantastic, and you featured information from the three-part podcast series, The Fifth Branch. Can you tell us about the series and also the focus?
Yeah, so thank you all for having me here. This has been always been a big fan of the Jam and a regular viewer, and so excited to talk with everyone today. So I work for Trade-Offs. We're a nonprofit health policy news organization, and we started reporting on 988 back in the lead up to the Line's launch, and did a three-part series on that, talking to many of the folks that we've heard from today and that have been on this call. And then we really wanted to, as we've been talking about with the continuum, as everyone knows, that was really digging in on someone to call. Then we wanted to move to that next step, someone to respond. And whereas, Ted and Matthew's work has been really great, that we've used in looking at kind of the numbers on mobile crisis and alternative response, we really wanted to dig in on what it looks like on the ground. So we wanted to go in and embed with a community that is doing this response work and see what's working, what's not, and what have they learned. And so we spent over a year working on this, talked to a lot of different communities, and really landed in Durham. One, because they are one of the, we talked to expert after expert who said that they are one of kind of the model programs, one of the leading programs in alternative response in the country in terms of how they think about this work. And they also were really kind of open to letting us be there with them on the ground. I mean, I went on dozens of ride-alongs with their co-response teams, their unarmed teams. I sat in 911 with their 911 call takers, as well as their crisis intervention folks or social workers in 911. I spent time with their follow-up teams that go, that are made up of peers and clinicians that go and try to, again, have that follow-up piece as well, like we've been talking about today, and really just trying to capture what it looks like to try to do this work in real time. And I think one of the things that was great about Hart and Durham is they're doing a lot of things really well, but they also aren't afraid to talk about the challenges and what is tough about this work, and really being open and honest and wanting to help other communities do this work well.
Yeah, and I love that, both the openness component that you're talking about, and when people are open to sharing their lessons learned, what they could maybe have done better, or what they can learn from, so that they can share, like you said, with other communities. So thank you so much for coming on. We were so excited to republish the article. Please also go check out the podcast series. Thank you.
Good series. Thanks, Ryan. Thanks, Stephanie.
Thank you.
So as we get ready to sign off, just a reminder for coming soon next week, feel free to please be excited about turning in to seeing the Fireside Chat with Dr. Art Kleinschmidt, moderated by Tanja. Week after that, we'll be bringing in Steve Appleton from the Global Leadership Exchange to talk a little bit more about our international work and crisis around the world. And having 29 countries around the globe that have participated in those crisis summits, we're really excited about him being able to come in and kind of share and continue to bring that kind of international scope into our Crisis Jam as well. So thank you for watching, and appreciate you all. Have a great day.